Thanks, Brad. So firstly, if we just look at some of the injuries that are associated with knee dislocations. I've also got some of these photographs, and it's not only the American football players that do this to themselves, but also the soccer players and the rugby players. And these are high energy injuries, as you can see, often associated with motor vehicle accidents and high energy sport. And they're devastating injuries. This is an X-ray of a tibia that's gone anterior dislocation. And looking again at the classification, this is the Schenck classification, which was modified by Wascher. And if you've got a KD1, that's a multiligamentous injury, but one of your cruciates is intact. KD2, which is a rare one, where you only take out your two cruciates. Then the KD3s, which are involving both cruciates and either your medial side, your MCL, or your lateral side with your LCL and posterior lateral corner ruptures. And then the KD4, which includes all the ligaments of the knee. And the difficult one to treat is the fracture dislocation, the KD5. So that's the Schenck. The Kennedy method was to look at the direction of the dislocation. You look at where the tibia is going. So if it goes posteriorly, you sometimes can save your anterior cruciate ligament. If it goes anteriorly, sometimes the PCL stays intact. And then you have the medial and lateral and rotatory directions. So the treatment of this is really as an emergency. Initially is relocation under sedation and a locked knee brace. Now, quite often they come to you and they've already been relocated, either spontaneously or on the field. But if they come dislocated, then that's the first thing to do. And then deal with a potential arterial injury. And, you don't have to take these to theatre if you just want to relocate it, but if vascular repair or reduction is not maintained or vascular repair is required, then a spanning external fixator can be used, but only in certain cases. And then acutely, you want to repair your lateral side, and then either acute or delayed, depending on the situation, you should reconstruct the other ligaments. So, it's not necessary to take the patient to theatre and do this, put these cross pins in, because they're going to end up with this, with a broken pin. And then it's a hassle, because then you have to take it out before you can do an MRI to plan for your surgery, and it's going to leave a hole in the articular surface like this. And then only then you can do your MRI to plan your reconstruction. You can see here that's the pin tract, and there's a ACL, PCL disruptions. So the first thing that we have to look at is a potential vascular injury, and this can come in a variety of guises. It can be a tunica, intimal tear, it can be an occlusion, an avulsion, a rupture, or a transection of the popliteal artery. And the problem with the popliteal artery is that it's tethered above and below the knee. Clearly prompt diagnosis and intervention is critical, and it's still controversial how to diagnose and treat these. So the seminal article from 1977 in the JBJS showed 32% incidence of popliteal artery injuries, and they had a high dislocation rate, especially if it wasn't treated within the 6 to 8 hour period. And 86% that weren't treated in that period had an amputation. And the remaining 2/3 of the remaining 14% had chronic ischemic changes. So the 6 to 8 hours is a critical time. A recent meta-analysis published in 2014 showed an 18% vascular injury rate, 171 out of 862 cases in total in a number of studies that were combined, and amputation rate 12%. So it's still a high amputation rate, even in today's advanced management. And it also depends on what sort of a dislocation you have, whether you get a vascular injury or not. So the KDLs, the lateral, the bicruciate and lateral ligament ruptures, has 33% in prevalence of a vascular injury. And the ones who classified according to the Kennedy classification, the papers that classified according to the Kennedy, had 25% in the posterior dislocation. So it depends on which one it is. And the diagnosis is still controversial. And the historical approach has always been, clinical examination is misleading and it's got catastrophic consequences, so everybody should have a routine angiography. People who argue against that approach indicate that there are complications related to angiography. There's a cost, there might be a delay in intervention, especially if you've got a critical limb, and they might have false positives. So a newer approach, according to the literature, is a non-invasive techniques and selective angiography. Here you can see the problem with clinical evaluation. You might, in this case, have a warm extremity and a good pulse, but you've got this intimal tear, and that might cause problems later on. Obviously, if you have hard signs, you should do an emergency vascular intervention. So what's been shown to have a good specificity and sensitivity is this ankle brachial index. And it's reasonably simple to do. It always sounds a bit scary, but you just take a Doppler ultrasound probe, measure the systolic pressure above the ankle, then measure the brachial pressure, the arm blood pressure, systolic, on the ipsilateral side, and divide the one by the other. And if it's more than 0.9, then your risk of having a clinically significant vascular injury is very, very low. So it's got a high sensitivity and specificity. Angiogram is invasive. Here you can see this disruption of the popliteal artery. This is a CT angiogram, non-invasive and also very accurate. You can also do a Doppler, color flow Doppler ultrasound. The radiologist can do that, or an MR angiography. So those are your options. So basically, your treatment of a vascular injury, if you have a patient who comes in with a vascular injury associated with a knee dislocation, is immediate relocation of the dislocated knee, and that will obviously then often bring back the pulse. And it's been found that 80% of patients with vascular injury needed repair. So there's still a 20% of patients that didn't need any repair and was treated with observation. And the treatment by the vascular surgeon is either excise the segment and do a reverse vein graft. The problems with it is it's a big open operation in damaged tissue. You have to harvest the vein. There's an increased time to retransfusion because it all takes a bit long. So you can end up with complications. So there are some newer approaches. The vascular guys are getting better with their endovascular approaches. And here you can see this is an on-table angiography. The popliteal artery is cut off here. Here they're advancing the catheter past the sort of disrupted area, put a stent in, do another angiogram, and you can see here the anterior tibial artery is also cut off, so they put another stent in, and after that you get better flow of the whole area. So this is a sort of a slightly newer approach. Overall, the outcome in this meta-analysis shows a 12% amputation rate and a 73% ischemo infection after a failed repair, and 27% because of late presentation. So you've still got a high, even in the patients who had intervention, have a high amputation rate. So I would think a sort of a reasonable diagnosis and treatment protocol is if you've got an absent pulse or a cold foot, you need immediate intervention. So you don't really need that much in terms of investigations in that scenario. So you get your vascular surgeon to take the patient to theatre, do it on-table angiogram, and do a graft or an endovascular procedure. At the same time, if the knee, if they do need to do a graft, then it's often a good idea then to put a spanning external fixator on. If you've got an asymmetrical pulse, so you've got a pulse, you've got a reasonably warm foot, but the pulse doesn't feel right, and you do the ankle brachial index and it's less than 0.9, then you can do a CT angiogram to see what exactly the damage is and what needs to be done. If there's a normal pulse and a good ankle brachial index, then consider observation in association with a colored duplex Doppler angiography, ultrasound scan. Moving on to the nerve, so we're talking about the common peroneal nerve. Again, in that same meta-analysis, a high incidence of 25%. The anatomy being that it's fixed around the neck of the fibula, and especially the deep branch is sort of stuck as it goes between the extensor digitorum longus and the tibialis anterior against the interosseous membrane, and it's prone to injury there. So we've seen that perineal muscles overall have a better recovery because the superficial nerve that supplies the perineal muscles are sort of a bit better protected in the substance of the muscle. Edinburgh study looking at 55 cases of knee dislocation. They had 14 common perineal nerve injuries, 25%, and the lateral injury, it would make sense, has the much higher incidence. In fact, all of the patients that had injury to the common perineal nerve had the KD3L, i.e. bicruciate plus the lateral side. 4 of them had complete nerve ruptures, and 10 had lesions in continuity. And we diagnose it really clinically. We've got loss of power of all the anterior compartment muscles, as well as the perineal muscles, and loss of sensation on the dorsum of the foot. Standard MRI can't really identify the nerve integrity. One can do nerve conduction and electromyography in certain cases. If we look at the outcome, what actually happens to these common perineal nerve lesions, we say that if there's a nerve lesion in continuity with less than 7 centimeters involvement, here you can see a nerve in continuity, but you can see it's sort of edematous and thickened and not happy looking, they all have a complete recovery in 6 to 18 months. Okay? If the lesion is more than 7 centimeters, then you've got a variety of outcomes with no useful recovery, which would be no motor function or MRC grade 2 in about half, and then there's useful muscle recovery in the other half. If there's a nerve rupture, none of them had any motor or sensory recovery. And the treatment is difficult, so it seems like a good idea to explore it at the time of PCL, posterolateral corner repair and reconstruction. And as I said earlier, all the ones that did have a nerve injury had this problem. So you're going to go in and repair your PLC. So at the time you can look at your nerve and come up with a prognosis. And the primary repair of the ruptured nerve is not really feasible because of the extensive injury and not really having nice ends to repair. You can do a nerve graft. It can be primary or delayed. But in a big study, it was shown that any graft that's more than 6 centimeters had a poor prognosis. So since most of the problematic injuries are the ones that have a lesion of more than 7 centimeters or a nerve rupture, that is probably not going to be very successful. What is quite successful is the late transfer of the tibialis posterior to the midfoot. And we don't seem to see the hindfoot valgus and flatfoot deformities that you sometimes see with this transfer, probably because of the perineal injury at the same time. So in summary, there's a complete recovery in about 21%, partial recovery of useful motor function in 29%, and no useful recovery in the other half. So in 50%, there's actually no useful motor or sensory function recovery. I see I don't have much time left, but if we quickly look at fractures, we can look at avulsion fractures or tibial plateau fractures. Firstly, looking at the avulsion fractures, your tibial eminence is your ACL or your PCL, your fibular head is your LCL, and your Sagan fracture is probably the anterior lateral ligament rather than the ITB, in fact. And if the fragment is big enough, you can reattach it. If it's too small, you can do a reconstruction of the ligament. But if you can fix it back, then it's worth fixing back these tibial eminence fractures, the ACL and the PCL. It often goes, obviously, with the root of the meniscus as well. Your tibial plateau fractures, Schenck classification, and there are various treatment options, but overall you want to restore your congruity, get a stable fixation to get the knee moving early, restore your overall alignment, and then avoid infection and wound breakdown. And these days, with our knee replacements doing so well, one could consider thinking about reversing that order and not worry too much about your articular congruity, but more about your infection and wound problems. So various ways of looking at them. I mean, this was treated with a temporary external fixator until the soft tissues had healed, and then bicondylar plating. I mean, obviously we worried about infection in this sort of scenario with pin tracks, and then going in and doing plating on both sides with stripping. And so, this might not be the ideal scenario, but in certain cases can be done. There's a hybrid external fixator in this scenario. This was your Schatzke 3 with a articular surface depression, and often obviously do these arthroscopically assisted to try and get your articular cartilage, your articular congruity back. At the same time, these people last year came up with a flow chart how to look at multi-ligament injuries in association with fractures, and I mean, basically you treat your fracture. That's the first thing you initially have to ignore your ligament injuries. You need to get your fractures to heal, and then depending on whether there's instability or not, and depending on the age, degenerative changes, and activity level, consider either ligament reconstruction or knee arthroplasty. Thank you very much.
Thank you, well done. There was a lot of information in a short period of time. I hope you were all listening. It was very concise and to the point. Well done.